All right. Bonjour, bienvenue. Hello and welcome to the 2025 Canadian Paramedicine Research Day Great Debate. We have four debaters here today. Carla, Sébastien, Marc, and Jen. None have a conflict of interest to declare at this point in time. They don't have any ownership of the things. All of these incredible individuals have their professional bios on the CanPRD site, so I'm not going to go into detail about all of their accomplishments, but just to quickly summarize where they're coming from, they are all advanced care paramedics. They are educators, researchers, clinical practice leaders, and very involved in various aspects of paramedicine. Combined, a very impressive quartet. Carla, Sébastien, Marc, and Jen work with Medivie Health Services West, Urgence Santé, Alberta Health Services EMS, and Emergency Health Services Nova Scotia, respectively. As you can see on the screen, they take their jobs very seriously. If you hopefully were joining us last year, and if you did join us for the great debate last year, you may recall that Carla is a licensed alligator wrangler and has now begun training for upping her game to tiger sharks, but very recently has realized this might not be an ideal move since she lives in the middle of Saskatchewan, not a whole lot in those lakes there. Sébastien runs an animal interpretation center and had, as of count last year, 200 chickens, a donkey, two gophers, and a platypus. Well, recently he's added a pygmy hippo, a blobfish, and a hamster. So if anyone has any other things to add, please just let him know. Marc, when we last met, was the winner of the 2022 Wayne Enterprises Best Paramedic Utility Belt Award, and you will be very pleased to know that he has regained this title in 2024 and has an upcoming Guinness World Record attempt for number of multi-tools that can be put on one belt while doing a headstand on a beach ball. We all wish you the absolute best of luck. And now Jen, the new debater to the group. This is her first time here. Though she is new to the great debate, she likes to stick to the past. She is here from Nova Scotia, so I have some inside information. And unbeknownst to many of her colleagues, Jen likes to rollerblade to work while listening to 80s power ballads on her Walkman and has a collection of neon-colored terry cloth exercise headbands that adorn her living room wall. It's quite a thing to see. It is amazing the things you're going to learn when you come to Canadian Paramedicine Research Day and the Great Debate specifically. So
next time I come to Nova Scotia,
you can work on those tiger sharks.
Well, I'll work on the tiger sharks, and I want to see Jen's collection.
Okay, we'll take you to see that. So each person was assigned a side, and it wasn't necessarily the position that they would have chose for themselves or they truly believe in. So please, you can chirp us all you want, but I would ask no hate mail or email to them afterwards. They were forced into these topics, and this is not a full review of evidence, but some liberties have been taken. The idea is just to design something to get you thinking about different perspectives on a topic, and we know that none of these are as cut and dry as we would make them sound. So have fun with this. As you can tell from the intro, it isn't meant to be extremely serious. Please go into the chat and let us know your thoughts. Add to the debate, chirp us, cheer the debaters on. Each person is going to have a few minutes to provide their side of the argument, then a bit more time to provide a rebuttal to their opponent. Today, we're going to have two debates. Round one is high quality CPR, manual or machine, or RCR de haute qualité, humain or machine. And this debate will be in English with French translation. And round two is pre-hospital sedation for agitated delirium, midazolam or ketamine, or sédation pour délire hyperactif avec agitation sévère, midazolam ou ketamine. This will be a French debate with English translation. If you prefer to listen to the first part of the presentation in French, please go to the interpretation button at the bottom of your Zoom window. It looks like a globe. Choose French from the list, and you will hear the interpreter speaking French. To switch languages later on, you can go to the button again and select your preference. Okay, let's get ready to rumble. First up, Jen and Carla are going to debate high-quality CPR, manual or machine. Let's see what you think before hearing their arguments. A poll is going to pop up here, and I would like to see what you think, to see what they are fighting against. So that poll should come up. We'll take a moment. Here it is. Let's give that a moment, and then we'll get started. Get warmed up, get stretched. Excellent. Not too hard though.
Think I'm ready.
No injuries.
I rollerbladed here, so I'm all set.
Oh, perfect. Good. Okay.
Practicing my shark wrangling techniques out back.
Okay. I mean,
On the
we have some great whites here. We don't have tigers, so if you come out this way, you can do a little bit. Okay, I don't know if those answers have come in. I don't see them. There we go. They just popped in. Okay.
Yes.
So,
okay.
Carla,
so Jen, you're going to just concede your defeat right now.
Hey, I'm ready. I got some work to do.
All right, let's go. If I can get my slide to advance. There we go. So I don't think anyone who has had to perform high quality compressions for any length of time could argue with me that seeing one of these devices arrive on your call is a huge relief. We all know these devices deliver perfect compressions and that humans cannot deliver perfect compressions for very long due to fatigue or distraction or in adverse environments. Don't just take my word for it. I have some papers to prove what I'm saying. In this study, they found that patients in the mechanical CPR group had a higher CCF and shorter pauses for defibrillation. Here's another one to reinforce my point. In the manual CPR group, the compression rate was 125 per minute, whereas the Lucas provided a consistent 112 compressions per minute, which I'll remind everybody is in line with the current guidelines from ILCOR on heart and stroke. Also, the percentage of compressions that achieved an adequate rate with Lucas was 71%, which is significantly greater than what was achieved in the manual CPR group at 40%. Let's talk about depth for a minute. This is extremely challenging with manual CPR, but not with mechanical. Adequate depth was significantly greater with the Lucas at 52% versus 36% with manual CPR. I would like to see Jen try to argue those numbers. Now, there may not be a lot of research on the topic of cognitive load and stress as it relates to using a mechanical CPR device, but I feel like it's worth discussing. I have attended to many cardiac arrest calls over the years, and I feel like many in the audience could relate to how much calmer and quieter the resuscitation becomes once the mechanical CPR device is applied and running. Not to mention the reduced stress for the team leader on these calls. I no longer have to monitor the person doing compressions, what we now call the CPR coach. I can concentrate on other aspects of the resuscitation, and I have an extra provider to help with some skills that may need to be done, like preparing medications, obtaining vascular access, or airway management, as well as someone available to obtain a history of events or medical history from the family, which is extremely important. These tasks can help immensely when we want to provide the best care we can to our cardiac arrest patient. Good luck, Jen.
Seems like you've got the data there, Jen. It's over to you.
I think we could just stop here probably.
No. We can't pass this up. Look, as somebody who has used the Lucas device on calls, I can attest to how quiet and calm it does make running a cardiac arrest. And I do appreciate that. But let's press pause on the mechanical device here for a second and do a pulse check. Have we become too reliant on it? Like Dr. Lang said this morning, is this novelty-based medicine? I don't know. Okay, so this isn't just my anecdotal experience. It is documented that clinicians and patients can become overly reliant on technology, leading to not knowing what to do when it's not available or it fails. Patients may see this on TV and expect it, leading to a perceived inequity of care. I would argue that it's a distraction at times. It could lead to time off the chest. Not everybody's comfortable with it, and it can be cumbersome, leading to potentially end user burden, which was found in this study. Being reliant on devices could lead to skill degradation. Again, like was found in this study here, we always need to know how to provide quality BLS care when we're off duty, at home, or in public places. But that's not just the only issue. I want to talk about patient safety here, okay? These devices cause injuries to our patients, okay? We have an abundance of literature here showing that mechanical devices consistently cause more injury than manual compressions. In a randomized trial by Boutet, it was found that significantly more sternal fractures and rib fractures happened when mechanical devices were employed. Another study by Andrushka showed that there were more pneumos, lung lesions, hemoperitoneums, and liver lesions when mechanical devices were used. This study here by Smecker, there was significantly more rib fractures. And a randomized controlled trial by Wick shows that there was again an increase in rib and sternal fractures. And then, of course, this report by Clinchar that states there was a case of a massive liver and spleen rupture related to mechanical compression devices. Have fun beating that, Carla.
Pulling out the patient safety. Carla, let's get your rebuttal.
Well, knowing Jen, I knew she would try to bring up some studies on patient safety and injuries to try to sway you to her side. But what she didn't highlight is some of those papers were pretty weak. I noticed a few lines in there that she chose to de-emphasize, like may have been related, or being significant, whether there was 6 rib fractures or 7. Now, don't get me wrong, patient safety is our #1 priority always, but some of those papers were a little misleading, Jen. However, look at this one. This study compared internal and skeletal injuries for both groups. Yes, there are injuries with mechanical compressions, but the difference between mechanical and manual was not statistically significant. There were injuries in both groups. Rib fractures were common in both groups, and bleeding was the most common non-skeletal complication in both groups. Good try, Jen. Let's spend a little bit of time talking about mechanical CPR and paramedic safety. This study showed that the Lucas device performed much better in a moving ambulance, not a surprise to any of us there. But we also can't deny how unsafe it is for a paramedic to try to perform manual compressions in a moving ambulance. It also can't be understated, there are some other unique situations where manual CPR is just not reasonable. This paper by RISM, they discuss cases of prolonged CPR, like greater than 50 minutes, and suggest that mechanical devices can increase the chance of favorable outcome in these situations. In this one by Wang, they concluded that mechanical compression devices used by trained individuals is a reasonable alternative to manual compressions in settings where consistent, high-quality manual compressions aren't possible or are dangerous for the provider. Some examples listed are limited resources, prolonged CPR, hypothermic arrest in a moving ambulance, etc. In the Pool paper, they found the use of mechanical devices in specific circumstances where high-quality compressions can't be safely delivered, a reasonable strategy. Now, in conclusions of most of the papers I reviewed on this topic, they emphasize that in all situations where mechanical devices are used, clinicians must ensure the device is deployed with minimal interruption to chest compression delivery. We know time off chest is terrible and very detrimental to patient outcome. Okay, Jen.
She seemed to have things against you, so Jen, let's wrap it up.
I haven't broken out the big guns yet. All right. So you make some points. I get it. You make some points here. Paramedic safety is super important. And, you know, my point is that we're so infrequently transporting these patients intra-arrest that clinician safety really comes into play such a small percentage of the time. But are we ready to hear why we have the biggest reason why mechanical devices are not superior?
Bring it on.
All right. It's just not better, period. Okay. No matter which way you slice it, these devices do not perform better. The only reason we're doing this is so that patients survive and so that they survive neurologically intact. And mechanical devices just haven't been able to beat our hands. So let's take a look at the literature to land the punch on this point. And don't worry, I'm not going to waste our time with anything less than just a ton of level 1 evidence, okay? So we have here the Link trial. None of their survival metrics had any significant results. None of them, not a single one. They conclude that mechanical devices do not improve outcomes compared to manual chest compressions. There we are there. Okay, on to the next. Let's look at this meta-analysis by Bones. These are the pooled results for survival neurologically intact, because that's what we're here for, right? These patients want to go home, hug their kids, go for the 2 for $20 deal at Applebee's, right? Look here, identical odds sitting square on the line of nothing interesting is happening here, okay? Next up, the Paramedic trial. This is a randomized control trial with a meta-analysis concluding no significant difference in 30-day survival. And the meta-analysis did not suggest that survival improved when compression devices were used. And you know what? It's tarps off time here, Carla. I'm going to say it. I'm going to say a naughty word here. Trend. I said it at Camp PRD. There's a trend towards favoring manual. All right. How do we feel about that? Are we done yet? I don't think we're done yet. Here's another one. Again, no significant findings in this meta-analysis of randomized control trials. The outcome of survival and good CPC score, again, trending towards manual compressions favoring. Okay, and still not done here. And now, the GOAT, ladies and gentlemen, of systematic reviews, Cochrane. And they found, you guessed it, the same. No significant difference in survival, neurologically intact. And that, ladies and gentlemen, is what we call a knockout.
Okay, any last slams of each other before we close this one off?
Well, I've got something to say. I'd like to clear something up here. So just because there's neutral evidence doesn't mean that it's evidence against. So if a compression device is just as good as our hands, why aren't we using it? If it's equal, then decreasing the stress of the paramedic and improving the patient safety or paramedic safety has to be considered.
All right, I get what you're saying. Maybe mechanical compression devices have a place used strategically in maybe a single response unit or when you're transporting intra-arrest, but they are simply not a replacement for good old-fashioned hands-on chest. Back to you guys.
Well, now it's your chance for the audience to tell us if Jen swayed you, doubtful, or if you remain on the machine side. And just one last comment from me, go Riders.
Oh, throw a note there. All right, well debated, both of you. Let's put that poll back up. Let's see what everyone is thinking, and then we'll head into debate number 2. So, have we swayed anyone? Where that poll is going to pop up? There it is. Let's see. There was meta-analyses pulled out there. There was swaying with attempting to pull people over to the CFL, and all right, let's see. Lots of comments in there.
Go
too.
Riders. See all the comments there. I knew it.
I think that's called bribery.
Thanks, Carla.
Hey, whatever works.
All right. Well, that poll is coming up, Sébastien, if you want to get your slides up there. So we'll transition over as soon as we get our winner. I need a drum roll or something. We need like a back drum roll. Oh, this
see any of the chat
Tense.
during that, so I'll have to look back.
Okay, here it is. Machine still wins, although there was a bit of a sway, but Carla stayed on for that one. Well done, both of you. A ton of great evidence in there. All right, let us move on.
Master Carly.
Okay,